anti-diabetic drugs. So already we have discussed the insulin, and this also we have discussed that what are the types in which insulin is mandatory. So where we can use oral hypoglycemic drugs or oral anti-diabetic drugs, if this point also we have discussed, if function of beta cells are intact. So two possibilities can occur. Either beta cells are releasing low amount of insulin, and number two, the insulin resistance. That means the function of insulin is not proper. What does it mean? This also we have discussed, because for the internalization of excessive glucose molecule from blood inside the cell, uh, is going to happen when insulin is going to bind with insulin receptor, and there is a conformational change, then internalization of glucose molecule from outside to inside. Okay, so these are the main groups of oral hypoglycemic drugs, and the number one is insulin secretagogues. That means these are the drugs, or the drugs which are included in this group. They are going to enhance or stimulate release of insulin. So that is why labeled as insulin secretagogues. And one thing you must remember, and this is important, now, at this level, we can discuss that if any oral hypoglycemic drug, if that drug is going to enhance insulin release, one of the problem as side effect definitely is going to occur. So that will have to monitor. What is that? Increased chances of hypoglycemia, right? So insulin secretion, increased chances of hypoglycemia. So that is why if we are going to prescribe insulin secretagogues, we'll have to monitor the blood glucose level closely, right? Because these insulin secretagogues can induce a hypoglycemic state, right? Second group, biguanides, and this is one of the group that is being used extensively nowadays, right? And one of the key example of this group is the glucophage, right? And one of the important why it's being used extensively nowadays in clinical setup clinically, because this group is not going to induce the problem that is called hypoglycemia. So that is why this group is being used extensively, and that we will discuss later on, the explanation why it's not going to induce a hypoglycemic state. The third group is the alpha glucosidase inhibitors, right? So alpha glucosidase enzymes which are present in the brush border of the intestine. So why we are going to inhibit this enzyme, that we will also check in the subsequent slides. The next group is the thiazolidinediones. This is another oral group. And then dipeptidyl peptidase 4 inhibitor. This is the enzyme dipeptidyl peptidase 4. And why we are going to inhibit this enzyme. And the key drug, sitagliptin. So again, this is another new drug that is being used extensively. And one more oral hypoglycemic drug group that we will discuss in the last slides, the new group, that is the sodium glucose co-transporter inhibitor, right? So at least you must know the classification, right? So sulfonylureas, maglutinides, amino acid derivatives. So these are insulin secretagogues. So it stimulates insulin secretion. Second, metformin, that belongs to which group? Biguanides group. This biguanides, metformin, insulin secretagogues. We have sulfonylureas, maglutinides, amino acid derivatives. And the third one is acarbose. Acarbose is the example of alpha glucosidase inhibitor. And what does it do? Slows glucose absorption, right? Because the carbohydrate ultimately converted into glucose, and then glucose is going to get absorbed and enter into the bloodstream. So, and this conversion of carbohydrate into glucose take place in the intestine with the help of alpha-glucosidase enzyme. So this carbos inhibit alpha-glucosidase enzyme. So we are going to delay the conversion of carbohydrate into glucose. So this is how we can reduce the level of glucose in the blood. Right. Another group, that is the thiazolidinediones, and the important point related to this group, it improves sensitivity of tissues to insulin, because again and again I have repeated the concept that in type 2 either insulin secretion is not sufficient, right? And the second, the mechanism is the insulin resistance mechanism, right? So this thiazolidinedione group basically improve sensitivity of tissues to insulin or decrease the insulin resistance phenomena. So indications for oral hypoglycemic drugs, they are used to lower blood sugar level in patients that diet and exercise have failed, right? And this is the logical points. The patient must have some pancreatic function left. This point also we have discussed. That is why we are prescribing oral anti-diabetic drugs, because for using oral anti-diabetic drug, the function of the beta cell must be intact. They can be used as a monotherapy or in conjunction with the other oral hypoglycemics. In clinical setup, we start a therapy with the single drug from the group, and generally the group that we recommend or prefer, that is the Biguanide group. The example is metformin. But if glucose level is not going to control, we can add another group. So at least we can use 3 or 4 different groups to control the blood sugar level. But in spite of that, if sugar level is not going to maintain, so ultimately we'll have to switch the patient to insulin. This is important point. So what are the contraindications of oral anti-diabetic drugs? No drug allergy. Maybe that patient suffering from drug allergy from one of the oral anti-diabetic drug. Active hypoglycemia, right? Usually not used during pregnancy. So subcutaneous insulins that we prefer. So during pregnancy, and this also we have discussed, that one of the problem nowadays is the gestational diabetes. So that persistently high level of blood glucose in the mother can be controlled by administering insulin. Liver disease, kidney disease, and depending on the metabolic pathways of the medication, right? If drug is extensively metabolized in the liver, so it must be avoided in liver disease. And if the drug is mainly excreted through kidneys, so in kidney failure patient, in renal failure patient, will have to be very, very careful to start this therapy with that drug that is actively excreted from the kidneys. Now, one by one, insulin secretagogues, we have 3 examples. One of the group is the sulfonylureas. This is one of the important group, the main group that we will discuss. There is another example, meglitinide and the phenylalanine derivatives, right? Like amino acid derivatives, right? But we are going to focus sulfonylureas. And already we have discussed insulin secretagogues means this group is going to stimulate or enhance insulin secretion. Clear? Okay. And now this sulfonylureas further divided into first generation, second generation, and some authorities suggest the third generation. But most of the authorities, they are focused on sulfonylureas that having this group having 2 main generation, first generation and second generation. In first generation, we have tolbutamide and chloropropamide. But nowadays, we are not using or almost the use of first generation sulfonylureas are obsolete. The reason is adverse drug profile and increased chances of drug reaction, right? Increased chances of drug-drug interaction. So that is why we are not using first generation sulfonylureas in controlling the blood sugar level. But yes, second generation is still being used, and the common example is glyburide, glipizide, and glimepiride. So there are other examples as well, but these are the common examples that at least you must know that belongs to second generation, and clinically we are using these drugs: glyburide, glipizide, and glimepiride. Sulfonylureas, it is to this all point also we have discussed sulfonylureas because it belongs to insulin secretagogues, and insulin secretagogues means these drugs stimulate insulin secretion from the beta cells of the pancreas, thus increasing insulin levels. Beta cell function must be present. This point is also very important, and it also improves sensitivity to insulin in tissues. The result is it will lower the blood glucose level towards the normal level, from high level to normal level, by decreasing the blood glucose level. First generation drugs not used as frequently now, and almost the use of first generation is obsolete. So mechanism of action, this is important, of sulfonylureas bind to specific receptors on beta cell of islet of pancreas, and it will block the ATP sensitive potassium channels. So when there is blocking of potassium channels, there will be no efflux of potassium, right? So it will lead to depolarization and opening of channel. So influx of sodium will take place, and influx of calcium ion into the beta cells, and this increased level of calcium due to process of depolarization, and this depolarization due to blocking potassium channels, it will increase release of stored insulin from beta cells. Pharmacokinetics, well, absorbed orally, that is why it's being used orally commonly. Highly bound to plasma protein. Here you can see, because this is one of the general concept. Any drug, if that drug having tendency to bind with plasma protein strongly, so what is the clinical importance? The clinical importance is that drug will show increased chances of drug-drug interaction, because any other drug, if that drug having more protein binding affinity, so it will displaces this drug from its binding site, or this drug sulfonylureas can also displace other drug from its binding site, right? So increased chances of drug-drug interaction, because any drug which is displaced from its binding site, what will happen? The increased level of that drug in the blood, so increased chances of toxicity. Have low volume of distribution. Most of them cross the placenta and may cause severe hypoglycemia in neonates. Metabolize in liver and mainly excreted in urine. That means if a renal function or liver function is not normal, so it is better to use another group of oral anti-diabetic drug. But if we think that this group would be more effective than any other group, then we'll have to monitor continuously the status of liver and kidneys. Adverse effects, and this is very important side effect. Hypoglycemia is common, and this is again one of the general concept. Any drug which is going to increase the release of insulin, so increase phenomena towards the internalization of excessive glucose molecule, so increased chances of hypoglycemia, right? GI disturbances like nausea, vomiting, metallic taste, diarrhea, and flatulence. Weight gain is due to stimulation of appetite. This is another very important side effect as far as the exam is concerned, because sulfonylureas, it can be given in a patient having low body weight. That means in obese person, This is very interesting point in obese person, and this point also we had discussed. Generally, in type 2 diabetes generally occur in obese person, but in obese person we are recommending that you should lose your weight, right? So we can decrease the insulin resistance, and if we start the therapy with sulfonylureas in already obese person, so it will further increase the weight gain. So in obese person, it is better to start the therapy with Biguanides. So this is important point. Weight gain is due to stimulation of appetite. This is another important side effect of sulfonylureas that is asked in the exam. And allergic reaction, because sulfur containing compound. So any drug having sulfur containing compound increase chances of allergic reactions, right? This is important point. And that means if a patient is taking other drugs for comorbidities, so again we'll have to check that whether this patient is already taking any other sulfur drug, because the more than one drug increase chances of hypersensitivity reaction or side effects. Teratogenicity, chloropropamide has disulfiram-like reaction that impairs the metabolism of alcohol and hence produces intolerance to alcohol. Contraindications of sulfonylureas, type 1 diabetes, because already we have discussed that for you starting the therapy with oral hypoglycemic drug, the beta cell function must be intact, and sulfonylureas main function is to stimulate insulin secretion. In type 1, when there is absolute lacking of insulin and destruction of beta cell due to autoimmune phenomena, so how it's going to stimulate the insulin secretion? So that is why we cannot use sulfonylureas in type 1. Pregnancy and lactation, this also we have discussed, because it can crosses the placenta, so it should be avoided during pregnancy, and it also comes into the breast milk. Significant hepatic or renal failure, right? So, in which there is no need to start a therapy with sulfonylureas. Drug interactions. This point also we have discussed, because why increased chances of drug-drug interaction? The key point already we have discussed, right? Any drug, if that drug having the tendency to strongly bind with plasma protein, so increased chances of drug-drug interaction. Clear? So hypoglycemic effect increases when taken with alcohol, anabolic steroids, and many other drugs, right? Because these anabolic steroids or alcohol, it will displaces sulfonylureas from its binding site. So free level of sulfonylureas. So increase chances of hypoglycemic effect, right? Adrenergic, especially which group beta blockers may mask many of the symptoms of hypoglycemia and hyperglycemia. Corticosteroid, phenothiazines, diuretics, oral contraceptives, thyroid replacement hormones, phenytoin, diazoxide, and lithium. So these are the examples of drug that will lead to hyperglycemic state. That means if these drugs are being used and at the same time sulfonylureas we are using, the effect of sulfonylureas are minimized due to the use of these drugs simultaneously. So that will lead to hyperglycemia, right? So allergic cross sensitivity may occur with loop diuretic. Again, this point also we have discussed, because loop diuretic, especially the furosemide, the Lasix, one of the famous drug, right? So that also containing sulfur compound, so increased chances of cross sensitivity allergic reactions. So example is loop diuretics and sulfonamide antibiotics. May interact with alcohol, over the counter medication containing alcohol, causing a disulfiram type reaction, in which we have facial flushing, throbbing headache or pounding headache, feeling of breathlessness and nausea. Now the second group, and this is one of the major group, important group, right? So in which we have metformin, and another name is glucophage. So biguanides, it decreases production of glucose. So it's not going to stimulate secretion of insulin. It's going to decrease production of glucose, and it also increase uptake of glucose by tissues. Right. So improve the insulin function. Right. Decrease the insulin resistance. So glucose molecules are taken up inside the cell. So decrease level of blood glucose. So doesn't increase insulin secretion from the pancreas, so it's not going to cause hypoglycemia. So this is one of the point. So this group is being used extensively because there is no chance of hypoglycemia with this group. Adverse effects primarily affect GI tract, abdominal bloating, nausea, cramping, diarrhea, feeling of fullness. So these adverse effects are clinically very common, and every patient who is taking a Biconide group, right, so will complain these problems. But these problems can be minimized if we advise the patient that you should take this drug with first bite of meal or in between the during the meal, right? So we can minimize the GI related side effects. May also cause metallic taste, reduce vitamin B12 level, but in a chronic treatment. This is the side effect which is asked in the exam. Lactic acidosis is rare, right? But lethal. This is important point. If it occurs especially in patient already have disease or comorbidities. So if a patient having liver disease or alcoholic patient or conditions that predisposed to tissue anoxia and lactic acid production like in chronic cardiopulmonary dysfunction, and that patient is taking metformin, so in these comorbidities increase chances of lactic acidosis. So fortunately this problem is rare, but unfortunately lethal. Okay, important point, use of metformin other than diabetes. This is one of the favorite question that is asked in the exam. Okay, metformin, which belongs to Biconide group. Is there any other important use of this drug? Yes, metformin is used to restore fertility in an ovulatory woman with polycystic ovary disease, right? And this is one of the common problem that occurs in our society related to women. In comparison to sulfonylureas, metformin doesn't cause hypoglycemia because it do not stimulate the release of insulin, and no weight gain. Rather, it will reduce the weight, right? So these are the important points. Uh, Now the third group, because sulfonylureas, the second group bigonides, in which we have the example of metformin. Now the third important group is thiazolidinediones, right? So in which we have pioglitazone or rosiglitazone. Avindia, this is one of the drug rosiglitazone that is being used extensively clinically, right? So also known as glitazones. So thiazolidinediones, it decrease the main function, decrease insulin resistance. Insulin sensitizing drugs, that is why it is labeled as increase glucose uptake and use in skeletal muscle. Inhibit glucose and triglycerides production in the liver. Mechanism of action, this is important from the BCQ point of view. Increase target tissue sensitivity to insulin by activating the peroxisome proliferator activated receptor gamma, right? PPAR gamma receptor, right? So activation of these receptors by thiazolidinediones, and this nuclear receptor regulates the transcription of genes encoding proteins involved in carbohydrate and lipid metabolism. Adverse effects, moderate weight gain, edema. This is one of the major concern related to the thiazolidinediones. fluid retention, right, and may increase the risk of myocardial infarction. Suppose if a patient having a heart problem and especially heart failure, in which already there is a problem related to edema fluid retention, so it will further enhance this problem. Mild anemia, hepatotoxicity, not common, but we must monitor the liver function. Why hepatotoxicity? We should keep hepatotoxicity in our mind, because the one of the parent drug of this group, thiazolidinedione, which was troglitazone, which is the parent drug or original drug of this group, has been withdrawn from the market because of serious hepatotoxicity. So that is why if a patient is on the current drug of thiazolidine drug, though they are not going to produce hepatotoxicity, but carefully we'll have to monitor for the safe side, because of its this group linked with the parent drug troglitazone, which has been withdrawn from the market due to serious hepatotoxicity. Increased risk of bone fracture in female patient. What does it mean? That means thiazolidinedione enhances or stimulate the osteoclastic activity. So that is why increased risk of bone fracture in female patients. So all these points related to adverse effects of this thiazolidinedione group is very important. Okay, drug interactions. Pioglitazone and rosiglitazone induce cytochrome P450 activity, especially the 3A4 isozymes, so can reduce the serum concentration of drugs that are metabolized by these enzymes like oral contraceptive pills and cyclosporin. And this concept already we have discussed again and again when we talk about the drug metabolism. Mainly drug metabolism, generally most of the drugs are metabolized with the help of P450 enzyme family, which are located in the liver, right? So some of the drugs, they can induce P450 enzymes. So the drug which are metabolized by these enzymes, the metabolism will be faster. So the level of that drug will be reduced due to early elimination of that drug, due to induction or stimulation of drug metabolizing enzyme. In another concept, if a drug is going to inhibit P450 enzyme, so there will be slow drug metabolism or inhibition of the drug metabolism. So the drug is not going to be eliminated from the body. The level of that drug will raise in the blood. So increased chances of toxicity, right? Now, the next group, alpha glucosidase inhibitor. This point also we have discussed. This is the enzyme which is present in the bridge border of the intestine, right? And this is the enzyme responsible to convert carbohydrate molecule into smallest molecule, which is glucose. So the key example is the acarbose, right? Another example is meglitol. Alpha glucosidase inhibitors reversibly inhibit the enzyme alpha glucosidase in the small intestine. So what will happen? Delayed absorption of glucose, right? So must be taken with meals to prevent excessive postprandial blood glucose elevation with the first bite of a meal. Adverse effects are very much important, because when there is carbohydrate molecule will remain in the GIT, so intestinal flora or bacteria can metabolize that carbohydrate and increase chances of production of gases. So that is why flatulence is one of the important side effect. Diarrhea, abdominal pain, but it doesn't cause hypoglycemia, right? Hyperinsulinemia or weight gain. Now, this is the new drug, but nowadays in the current clinical setup, one of the diabetologists, they are using this drug sitagliptin and other derivative of this group, which is basically inhibitor of dipeptidyl peptidase 4. And very interesting point that this sitagliptin is being used as a single drug or a combination formula. Like sitagliptin can be given with metformin, with a combination of sulfonylureas, right? So what is this sitagliptin? Basically, sitagliptin is an inhibitor of dipeptidyl peptidase 4 enzyme. So why inhibition of this enzyme is necessary? Because this enzyme, dipeptidyl peptidase 4 enzyme, it degrades incretin and other glucagon-like peptide, right? So why, if there is degradation of this incretin and glucagon-like peptide, so what? Because this incretin basically is released from the endocrine cells of the intestine in response to food. And basically 60 to 70% of the insulin is released due to this incretin endogenous endocrine secretion, right? So if there is breakdown of this incretin, which is responsible to stimulate the 60 to 70% of the insulin, right? So what will happen? Decrease level of insulin. So if we inhibit its breakdown, right, so what will happen? Increased chances of insulin release. That already we have discussed. This incretin is responsible to stimulate 60 to 70% of the insulin in response to food. So that is why we are going to avoid its breakdown, its degradation, because the degradation or breakdown of incretin and other glucagon like peptide, they are degraded by an enzyme which is called dipeptidyl peptidase 4. So why we are interested to inhibit its degradation? This point already I have told you, because this incretin, that is the endogenous endocrine secretion that is released in response to uh, food, and this incretin basically responsible to stimulate 60 to 70% of the insulin from the beta cells. Clear? So that is why we are going to inhibit is degradation, and we can maintain the maximum level of insulin secretion. Clear? So it decreases postprandial glucose by increasing glucose mediated insulin secretion and decreasing glucagon levels. Common adverse effects include nasopharyngitis, upper respiratory infection, and headache. So that means if a patient having respiratory infection, so and that patient is on sitagliptin, this problem can be enhanced or severe. Rarely it may cause severe allergic reactions. Doses should be reduced in patient with renal impairment, because this drug is being eliminated through kidneys. Now this is the most current group that is being used, and that is the sodium glucose co-transporter 2 inhibitors. And examples are canagliflozin and dapagliflozin. And mechanism of action, it will inhibit the sodium glucose co-transporter type 2 enzyme, because this enzyme normally, first understand the mechanism of this enzyme. This enzyme is responsible to enhances the excretion of excessive glucose through renal route, right? So, inhibition of this sodium glucose co-transporter inhibitors, because this enzyme normally prevent the excretion of glucose in the urine, because normally there is no traces of glucose in urine, right? Why? Because normally this enzyme, sodium glucose co-transporter 2 enzyme, normally prevent the excretion of release of glucose in urine, right? So when, if we inhibit this enzyme, what will happen? Decrease reabsorption of glucose, and it will increases urinary glucose excretion. So this is one of the phenomena that we can decrease the blood glucose level by enhancing release of glucose in urine. So what will happen? It will cause glycosuria, that means excessive glucose in urine. And inhibition of this sodium glucose transporter 2 also decreases reabsorption of sodium and causes osmotic diuresis, right? Because I don't understand the question, sir. Is not this a transporter? Because in our body there are different channels, there are different transporter system that can control the secretion or excretion of different compounds, right? So this is one of the transporter system that normally prevent the excretion of glucose in normal cases in urine, right? So if we inhibit this transport system, now there is no check related to glucose excretion. So excretion of glucose in urine will enhance. So in diabetes, where we cannot control the excessive glucose level by conventional oral hypoglycemic drugs, so we can use this drug, right? And this when we inhibit this transporter, one phenomena enhances the excretion of glucose in urine and enhances the excretion of sodium as well. That means sodium is not going to get absorbed. It will remain in the lumen, so it will catches water from inside to outside, because water molecule will move from low solute to high solute concentration towards the sodium. So when there is inhibition of the reabsorption of sodium, sodium is accumulated in the lumen, right? So it will catches water, so it can cause osmotic diuresis, right? So adverse effects, the most common adverse effects with sodium glucose transporter 2 inhibitors are female genital mycotic infections, for example, vulvovaginal candidiasis, urinary tract infection, and urinary frequency in both male and female. Hypertension has also occurred, right? Particularly in the elderly patient on diuretics. Now, this is all about the oral hypoglycemic drug. The most currently used that also we have discussed, that is the sodium glucose co-transporter. And now there are some preparations which are not insulin, because normally insulin preparation given parenterally, right? And most common route is the subcutaneous route. Now we have discussed the oral hypoglycemic drugs. Now there are some preparations which are administered parenterally, but they are not insulin, right? So one of the example is synthetic amylin analog. So amylin is a hormone that is co-secreted with insulin from beta cells following food intake, and it delays gastric emptying. What does it mean? What is the importance of this delays gastric emptying? Because it will uh, feel the fullness of stomach, so that patient is not going to take meal again and again, so we can avoid the raise of blood glucose level, right? So when it delays gastric emptying, so always patient is always feeling of fullness, right? So decreases postprandial glucagon secretion and improves satiety, right? Example is synthetic amylin analog. Example is pramlintide, that is a synthetic amylin analog that is indicated as an adjunct supportive drug to mealtime insulin therapy in patient with type 1 and type 2 diabetes, right? So pramlintide is administered by subcutaneous injection immediately prior to meals. But one important point we must remember related to this amylin analog, which is pramlintide, risk of severe hypoglycemia. But this risk of severe hypoglycemia can be minimized if we reduce the dose of insulin up to 50%, right? So when pramlintide is administered with mealtime insulin without the reduction of mealtime insulin dose by 50%, then there is a chance of risk of severe hypoglycemia. Other adverse effects are nausea, anorexia, and vomiting. The last group, that is the incretin mimetics, and already we have discussed about the incretin. This is very important compound. So glucagon like peptide is a member of the incretin family of peptide hormone, which are released from the endocrine cells in the epithelium of the bowel in response to food. This point already we have discussed. Incretin is released from the endocrine cells of the GIT in response to food. And what is the importance of this incretin? Because this incretin basically responsible to enhance the insulin secretion up to 6 to 70%. So the incretins augment glucose stimulated insulin release from pancreatic beta cells and retard gastric emptying, inhibit glucagon secretion, and produce a feeling of satiety, that is feeling of fullness. Okay, I have no desire to take further meal, I am full. This is the explanation of this. So exenatide, this is the example of this incretin mimetic, a long-acting injectable peptide analog of glucagon like peptide 1, which is used in combination with metformin or a sulfonylurea for treatment of type 2 diabetes. The major adverse effects are gastrointestinal disturbances, particularly nausea during initial therapy, and hypoglycemia, especially when exenatide is combined with sulfonylureas, right? The drug has also caused serious and sometimes fatal acute pancreatitis. So this is one of the point that can be asked in the BCQ. I think this is all about. So there is no need to take candies or chocolates if your sugar level is not in control status. So this is all about the uh, anti-diabetic drug, right? So if you have any question, so okay, shall we leave now? Okay, Ji. Thank you. Okay, okay. I think there is one question. Okay, can you show the last slide? Okay, last slide. This one or this one? The major adverse effects of this exenatide are gastrointestinal disturbances, particularly nausea during initial therapy and hypoglycemia, right? No, already we have discussed, right, why metformin is being used most commonly, because one of the major advantage is it's not going to produce hypoglycemia, which is a major concern. If a patient is taking insulin or other drug, that can cause hypoglycemia, right? Number one point. Second important point, it's going to reduce the weight, because generally type 2 diabetic patients are obese patient, right? So this is one of the reason. Okay, thank you.